Welcome back. This is a really exciting part of our day today, where hopefully everyone enjoyed the workshops and you're getting lots of takeaways from the event so far. We have a lot more to come. There's action-packed second half of the day. So for this next section, we are going to get to hear directly from a panel of our very own founders here for the NCIHC. So in order to do this panel, we're really excited to also be able to bring to the virtual stage the facilitator for the panel, who is Ignatius Bao. I'm going to give him a proper introduction because if you don't know him yet, you definitely need to know this individual. Let me go ahead and pull up my notes here so I don't miss anything, because there's a lot I want to say about Ignatius. Ignatius Bao is a national consultant and master strategist when it comes to social change. He's been working for language access for at least the past 20 years. A child of immigrants himself, Ignatius has been long keenly aware of the impact that poor language services has on the immigrant and refugee communities. In the early 2000s, while working for the California Endowment, Ignatius was instrumental in providing funding for several of NCIHC's on-site annual meetings for the establishment of the California Healthcare Interpreting Association, or as many of us know, CHIA, as well as for the critical projects such as the development of national standards of practice and the national standards of healthcare interpreter training programs. Ignatius has facilitated several annual meetings for the council and helped us with strategic planning as the organization has grown. For good reason, in 2010, NCIHC named Ignatius Bao a language access champion. We now know him as a keen observer, a strategic thinker, and a friend to us all. With that being said, we'll go ahead and welcome Ignatius to the stage.
Thank you, David, for that generous introduction. And I'm really excited to be able to facilitate this conversation with some of the founders of the National Council. So with that, let me welcome the founder panel to join me up here on stage. So as folks are joining us, we're going to keep with the theme of Back to the Future and do a little bit of reflection on the past, but also talk about the challenges that we're currently facing in 2023, and then end hopefully on some positive, hopeful notes as we look to the future. So I'm going to introduce the founders that we have on our panel one by one and ask them to share briefly. I'm not going to do long introductions, just share what they were doing in 1998 that helped found the National Council on Interpreting in Healthcare, the roles that they were playing. And so let me start with Dr. Maria Paz Beltran Avery, who was working with the Massachusetts Medical Interpreters Association to develop one of the first standards of practice for healthcare interpreters, and then also went on to develop one of the first college-level training programs for healthcare interpreters. So Maria Paz, say a little bit about how you became involved with the National Council.
Thank you so much, Ignatius. Yes, that was a very interesting journey that I started. I was working at that time in the early 90s at Education Development Center in Massachusetts. And we had just received a grant to develop a community college level certificate program to train medical interpreters, as we were called at that time, medical interpreters, not healthcare interpreters. And I knew, being in Massachusetts, that I definitely had to partner with the MMIA because that was the way to go. And that I had to make sure that I had the blessing of Raquel Cashman, who was the driving force for medical interpreting in Massachusetts, but also well known nationally. So I got an appointment with her so she could interview me. And of course, her first thought was, why are you doing this? You are not an interpreter. And why should we trust you? So I kind of got a gentle but very pointed grilling from Raquel Cashman, where I had to explain that I thought the background that I had working as a community organizer and also as a mental health therapist in the Latino communities in Massachusetts, that this gave me some credibility, as well as the fact that I was also an educator and had been involved in trainings with teachers and administrators on bilingual education and multicultural education. So one of the things that Raquel helped a lot, especially in the beginning, was that she helped me put together a small group of a diverse group linguistically and culturally who were interpreters. And we engaged in what was called the DACUM process that helped us identify the duties of the major duties of a healthcare interpreter. And as we were working on that project and getting to its end, she had gotten an invitation from Dr. Robert Putch, who was putting together a national working group of medical interpreters. And she obviously, was going, but she said to me, I think you should call Dr. Putch and get him to invite you. I'm like, okay, I will do that. So I called Dr. Putch, and of course, I got another grilling, which was, who are you? And what are you going to contribute to this? You're not a healthcare interpreter, and you're not a medical person who works with healthcare interpreters. So I finally convinced him and got invited to the first meeting that was held out in Seattle. As it turned out, I eventually ended up facilitating all the meetings of the National Working Group up to, and I think a little bit beyond the initial formation or the decision to become a National Council on Interpreting for Healthcares. And I have to say, it was an honor to facilitate these meetings of this amazing group of people who were dedicated, passionate, had no problems disagreeing vehemently with each other during the meetings. I had to tone some people down, but always at the end of the day, we came to agreement. And that's how I got involved and continued to stay involved with what then became the National Council on Interpreting in Healthcare. And that's my story.
Thank you so much. And for moving into that role and ending up being the facilitator rather than just the contributor. That's a great story. So let me turn next to Eduardo Berenstein, and you were also working as an interpreter and translator in Boston, also working with MMIA at the time. So how did you get involved in the National Council?
Okay, so in 1998, I had been already working as a medical, legal, and conference interpreter for 15 years. My medical interpreting career spans from 1985 to 2006. I started working as a freelance court interpreter in 1983, and then in 1995, I got my first job as a Spanish interpreter patient advocate at Boston Children's Hospital. After working there for 8 years as one of the 2 hospital Spanish interpreters in 1993, I was asked to start a multilingual interpreter program. So that was my motivation to get involved initially. And I networked with my peers from other hospitals who were doing the same type of work in a group that then was called the Massachusetts Medical Interpreters Association. There, I joined a committee of the association that was formed by a group of like 25, 30 interpreters interested that came to meetings in developing standards of practice, because Raquel Cashman, our founder, insisted that we needed to professionalize our field. So I was part of that working group, and that's how I got to meet Maria Paz and work with her. And I want to mention this group of people that got together for during a weekend for 2-3 days in a catered meeting where we debriefed on everything that all the tasks that the interpreters did. And Maria has experience in this process, developing a curriculum. Okay. And we came up with a list, was eventually refined into standards of practice. That's how I got involved into the group. And then The group that we did was informed by a constant exchange with people from two other places in the United States, Seattle and Minnesota. In Seattle, there was Cindy Rode, Robert Bush, Dr. Joe Crawford. In Minnesota, Bruce Downing. And for me, very important and influential was that with John Necros, who used to be the MMIA president for a while, we co-chaired the education committee, and we co-chaired joint education workshop for spoken language interpreters and sign language interpreters with Northeastern University, with Dennis Coakley, who also unfortunately passed away. But anyway, he wasn't a leading expert in the field. This fruitful exchange, I forgot that I was a member, a founding member. I just remember that there was this working group that published papers. I was asking before the meeting because the National Council now is known for the website and all the wonderful stuff that got published there, but it got started by a working group that met. And I met many of the people in this meeting in Massachusetts and in Chicago, in different places. And at the beginning, it was just working papers. There wasn't a website even. So that's my story of how I got involved with this group and how I got to meet so many of these people.
Thank you, Eduardo, and thank you for continuing to acknowledge many co-founders, many other people who were influential thought leaders early on in really developing the profession that is now the healthcare interpreter profession. So let me go next to Dr. Cornelia Brown. And Cornelia, you were the founder and executive director of the Multicultural Association of Medical Interpreters in New York. How did you get involved with the National Council?
Okay, I wrote something I call a love story. So I had a 1989 postdoc in Leningrad. I improved my Russian and fell in love with a Russian violinist. Back in the US, we got married. 7 years later, I was finishing a stint teaching at Hamilton College. My Russian husband was treating cancer patients, our son in kindergarten. My Russian in-laws had just arrived as refugees, joining 20,000 other refugees in Utica, 1/3 the population. Mir and Leonid visited many doctors. I accompanied them as an untrained interpreter, dictionary in hand, to check my terms. But how was I going to check about the interpreter's role? For example, if my father-in-law whispered to me in Russian criticizing his heart doctor, did I interpret his comments? I took my in-laws for TB tests, and the lead public health nurse saw my language struggles and shared her own. Her monolingual nurses had to tell speakers of Russian, Bosnian, Vietnamese, and Spanish how to report to them by phone the appearance of the Mantoux patch on their skin. At the time, there were no trained interpreters, medical interpreters anywhere. The health department couldn't do basic tasks. She asked me to join her in establishing an interpreter program. We train and dispatch interpreters. We'd allow medical facilities to comply with the 1964 Civil Rights Act, and we'd create a valuable profession for bilingual refugees. We'd enable doctors to treat non-English speakers. Linda could connect us to far-flung advocates. So excited, I said yes. We talked to the New York Task Force on Immigrant Health, Francesca Gainey, and through her to the National Council on Interpreting in Healthcare. Buoyed by present and future alliances, Linda and I organized potential interpreters and incorporated in 1998. We chose a name with a memorable acronym, Multicultural Association of Medical Interpreters, MAMI, when in trouble, call mommy. The task force gave our first interpreter training in 1998. That same year, I was honored the council elected me to its board. I fell in love with a person and then with a profession.
Thank you for that poetry and for that story, Cornelia.
Yeah.
So then let me move across the country to Von Nguyen, who developed interpreter services. These are all pioneers who, before there was such a thing, developed these services that gave so much assistance to people who couldn't speak English. therefore enable them to access healthcare in a more meaningful way. So you were working at Pacific Medical Center, and you eventually went on to develop the Medical Interpreter Forum, which then became the Society of Medical Interpreters. So Tuvan?
Hi, everyone. Wow, 25 years. What a reminiscing back, not 1998, but I went back to 1980 when I moved to Seattle from Spokane and heard that they need a Vietnamese interpreter. So I applied, and it was an office of Indo-Chinese Language Bank that was housed at Pacific at that time, USPHS. Cindy, you remember those? United States Public Health Services. There was no PACMED then. So I was hired, Sherry Riddick and John Reese interviewed me, and they say, Yuan, you speak English, you're good. You're just out of college. But I said, what? You are the family health worker now. I said, okay, family, that's okay, but health, what do I know about health? So in short, I was the family health worker hired by Indo-Chinese Language Bank and serving all the refugees who came at that time from Indochina. That's what they call Indochina. Laos, Cambodia, Vietnam. So at that time, I traveled to different clinics in Seattle, Gessler Terrace, Carolyn Down, Odessa Brown, Country Doctor, Rainier Vista Clinic. Oh my gosh, running back and forth. So after 3 years with Indo-Chinese Language Bank, PACMED changed name to Seattle Public Health Hospital, and shortly Pacific Medical Center. I was interpreting every day at the hospital. So one of the nurses, Jill Bradley, bless her soul, she's gone. She said, Tuvan, we need you in here, okay? You know how to deal with it. Because I told her, hey, I was walking the hospital and they grabbed me. They say, hey, you speak Cantonese? I said, no, but I speak Vietnamese. Sure, you can help us. It turned out the patient speak Cantonese. Sure, we have black hair, yellow skin. But so that's how I said, wait, why do people just keep asking me, you speak Cambodian? You speak Laotian? You speak this, you speak that? I said, no, I am from Vietnam. Oh, don't you speak Cambodian too? I said, no, I know how to say thank you in Cambodia, in Cambodian. So that's how I start with this, dealing with language and dealing with, how do I do this in health? So working at different clinics, the nurse showed me and kind of trained me on, okay, this is how blood pressure, this is how to use condom, how to use medicine, birth control. And soon I end up I was hired as an interpreter service coordinator since 1983 until 1998. And during that time, interpreter services coordinator changed to also create cross-cultural healthcare program. And there's a need, and of course you mentioned Dr. Pudge, who is so supportive of medical interpreter, language. So he put together a group of doctors, and we start to have a dialogue, a forum, and then we start a Society of Medical Interpreter Forum, so that interpreters can come together, express their need, and have some training support. Because a lot of people hey, you speak the language, let's make you a medical interpreter, right? So after that, I left PACMED and then went to Medallia Healthcare, try to create, it's called cross-cultural clinic and department for Medallia, but Medallia did not last long. So since then, I've been doing freelance medical interpreter in labor delivery, Vietnamese, and almost acting like a doula for 10 years, and doing a project for Fred Hutchinson on a project on women, how to understand their body and seeking healthcare. So, and then after then, I have not worked much since 2008 until I retired last year. Now I'm going back to do more medical interpretation, and I enjoy that. So that's how I get into this beginning. And of course, when I was at PacMed, it was so nice to develop that whole department. I run it with 40 interpreters from all over, different languages. And Cindy came and joined us and helped us with all the development of the medical interpreter services, the translation, the cross-cultural healthcare.
Thank you. So that's the perfect toss to our next panelist, our next founder, Cindy Roque, who was working with Tu Van and other interpreters in Seattle, and also pioneered one of the first trainings for healthcare interpreters. And I consider Cindy as the organizer among all of you, as well as a real thought leader. And so Cindy, share a little bit of your story.
Well, thank you. In the early 1990s, I had just graduated from graduate school with a degree in international public health, intending to go back to Latin America, where I had been working in rural areas doing rural development. But history conspired to make it very hard to get a job. And I ended up starting to do healthcare interpreting literally because I had to pay the rent. And a lot of us at that time got into interpreting through the back door like that. And one of the themes I hope that all of you who are listening will hear is that we were a bunch of people that, with a few exceptions, like maybe Shiva, had no particular expertise in any of this. We were making it up as we went along. But I was doing freelance interpreting in Seattle, and I applied to a position at the health department. And Sherry Wilson, some of you from Seattle will remember Sherry, who has left us, unfortunately, she passed on. Sherry said, well, I'll hire you as an interpreter because you're a good interpreter, but I think you'd be better for this new position that just opened up at PacMed Clinics. And it turns out that Dr. Putch, who was a physician at PacMed Clinics, had gotten that Tu Van talked about how they had been talking internally about cross-cultural care. And he had managed to get a grant from the Kellogg Foundation to pull together a program called the Cross-Cultural Healthcare Program that would talk with communities about what they needed to get culturally appropriate care. And one of the programs there was a program that Tu Van mentioned earlier that she was running, which was a interpreter forum. It was once a month in the evenings, basically continuing education for interpreters who'd never had any basic education, which was everybody. None of us had any basic training as interpreters, but we did have these once a month continuing ed things. So I was working part-time with the cross-cultural healthcare program and part-time as a staff interpreter. And Tu Van was my boss. She was a great boss. Thank you, Tu Van. Appreciate that. When Bob, again, talked to Kellogg about getting some money to pull everybody together around the country, because we realized that we were trying to do this work here in Seattle around language access. And we knew there was work going on in Boston. And we knew there was work going on in Minneapolis and a little bit going on in California. But this was before the internet, and nobody was talking to anybody because we didn't know each other. So Bob got this grant, and basically we just tried to contact everybody we knew around the country and up in Canada that was working around these issues to have us all get together in Seattle. And this was in 1994 for the first meeting of the National Working Group on Interpreting in Healthcare. And that's, and I got involved in that because I was running this interpreter forum, very excited to meet all these people. And soon after, or maybe it was soon before, I can't remember the timing, ended up being tasked with leading the development of a 40-hour curriculum with a training of trainers attached for healthcare interpreters called Bridging the Gap. And some of you may have heard of Bridging the Gap. So that's how I got involved. And of course, meeting all of these passionate, interested people who had very different ideas about what a healthcare interpreter ought to do. For all the way from, you know, the black box, render in one language, what was said in the other, and if nobody understands it, it's not our problem, to the other end of the spectrum, which was, you know, interpreter as social worker and responsible for the good outcome of the appointment. And we really did have some great battles. But interestingly, because we had Maria Paz facilitating, she kept us all in the room. We had no knockdown, drag out fights, although I think we might have gotten close a couple times. And little by little, we started to coalesce into a more agreement, if not total agreement still, but more agreement on what this ought to look like. So that's how I got brought in through the cross-cultural healthcare program. And it has really shaped my life for the last 30 years. Thank you to all of you.
Thank you, Cindy. And I didn't plan it this way, but each of you are providing the segue to the next panelist. So Shiva Vidayaseloff is interpreter, worked with the council on code of ethics, standards of practice, and now continues leadership within the health system at the University of Wisconsin Health as a vice president and chief diversity officer. So Shiva, go back, and how did this all begin for you?
So thank you so much. Such a great pleasure to be here and to follow my great friend Cindy. Again, we did kind of start our paths together way back. So I was trying to think back, but my first recollection is actually connecting with Cindy and Maria Paz and others around, hey, I bring actually interpreter background. I was trained actually with a master's degree, and prior to that with a bachelor's degree in interpreting and translation in Europe. So I thought, okay, like I can bring the interpreter background and really like work on this. At the time, I was the first interpreter trainer at Language Line Services. And we'll make full circle, I think, about technology and interpreter services during this call. But at the time, there was a lot of pushback about the use of phone interpreter at the time and what that really meant and how did that really respond to the culture and other needs that would happen when interpreters were in person. So because I was bringing kind of both the interpreter training background as a trained interpreter and also this kind of work within Language Line, I was able to join the group, and we did indeed spend a lot of time with Maria Paz leading us to a lot of facilitated conversation in trying to first get to some place of general understanding, I would say, maybe even more than agreement of what the role of an interpreter was, could be, should be. The 1998, when I think about that, is actually the year after I started as the first Spanish medical interpreter at UW Hospital and Clinics, and medical interpreter and coordinator of interpreter services. It was like the one woman show that I was running here. It was also the year again as we started really officially from the working group meetings to having the National Council on Interpreting in Healthcare. I was a member of the founding board with many again of my friends and colleagues here. And for a number of years got to work both as at some point co-chair of the board, but also very much so as co-chair of our standard training and certification committee. And from that, I want to say from day one, we had a committee that was called Standard Training and Certification, because we always thought we needed to go first with standard, then making sure there is the right kind of training, and then have certification. So here we are. Again, thank you so much. Great to be on this panel.
Thank you, Shiva. So last but not least, we have Dr. Julia Pueblo Fortier, who came from a totally different background, similar to Maria Paz, was working in public policy for Representative Henry Waxman, was really involved in the development of the national standards for culturally and linguistically appropriate services, the class standards at the Office of Minority Health. So Julia, talk a little bit about your connection to the council.
Sure. So thanks very much. It's really lovely to reconnect with all of you again. It's been quite a long time since I've been out of the United States for quite a long time too. So, I mean, I think I first became sensitized to these issues when I was growing up, because I grew up in a bilingual, bicultural household. And when I first came to Washington, D.C., I actually did some amateur Spanish language interpreting at a free clinic in D.C. And so got to see some of those issues firsthand. But I think when I first really became passionate or interested in these issues on a broader level was when I got a visit from some folks from California, from Sherry Hirota and Lauren Mayano and Linda Okahara, who were representing the Asian community health centers. And we were in the process of trying to put together the first Disadvantaged Minority Health Improvement Act. So this was around 1989, 1990. And they came to say, look, you know, there's not a lot of attention to these needs in the federal government's community health center program. But this is our work, this is our life. And we need to get some recognition for the money that we need to be able to have medical interpreters. And so we, with Congressman Richardson, who also sadly recently passed away, and Congressman Mineta, who's been gone for a while now, three of us congressional staffers spent some time trying to figure out how do we create something in this legislation that might recognize the need for medical interpretation. And from that point on, we were successful. And as part of my research to understand what is medical interpretation in the United States today, who does it, and how is it done, I started to talk to people around the country and got connected with Bob Hutch, Bruce Downing, folks in Seattle, folks in Massachusetts. And through my interest and perhaps my persistence and my kind of advocacy mindset, I started to attend some of these early meetings, the MMIA meetings, the meetings that were organized in Seattle. And I think my message all along the way was, it's not just about the interpreting, but it's about the context. It's about the healthcare systems. It's about policy. It's about funding. And so how do we sensitize the whole healthcare system to be receptive to medical interpretation? And so eventually I left the Hill. I was really supported by another key person, Pancho Chang, who was at the Kaiser Family Foundation early on and was able to organize a national meeting of cross-sectoral stakeholders in Washington, D.C. in 1995. And that brought together some of you and, but also people from the Joint Commission and from NCQA and some of the national policy leaders who we felt really needed to get more on board with these issues. And so that began a very long, but very interesting process of trying to develop policy instruments like the class standards. And at the same time, sort of moving into this outside of policy role, but more into a advocacy, communication, sharing resources, sharing best lessons, really trying to connect people through the DiversityRx website and through our conferences, and trying to circulate information about everybody's good practice and everybody's policy advances. And that led to Cindy and I being pulled in to be the first co-chairs of the National Council in 1998. And, you know, all the work that's really moved on since then. So really great to have brought that kind of agitating, let's look at the big picture, let's think about policy view of all of these issues.
Thanks so much, Julia. And this is a great trip down memory lane to hear names that we may not have heard of or have thought of for a long time. And so really appreciate everybody bringing these stories forward. So let me transition then to, we are no longer at 1998. The world has changed. We are now in 2023. And while language access seems to be much better understood by many health systems, health plans, health providers, there's still a lot of challenges. I think COVID really, again, highlighted the need for flexibility, for multiple modalities, but also the importance of having language access to avoid disparities, that if there wasn't language access, then those disparities are going to be apparent once again. And so let me turn first back to Maria Paz and talk a little bit about what you see as the challenges today for healthcare interpreters and the field of healthcare interpreting and language access overall.
Yes, I think that's an interesting question, because while we have moved forward in terms of the acceptance of healthcare interpreters in the medical world, I think, as you said, Ignatius, there are still many misconceptions about what the role of the healthcare interpreter is, what the value is of a really well-trained, a professional healthcare interpreter can be to the medical world. And I remember being at a meeting some time ago where there were members of the medical establishment there, administrators and presidents of, hospitals and so on. And I said to them, there's something I don't understand about the decisions that you make. You all are willing to invest millions of dollars in getting equipment such as MRIs and CAT scans and so on, and yet you're not willing to invest in a resource that can bring to you sort of, especially in a situation where you have a patient and you don't speak the same language and you don't share the same cultural background, and where language is actually one of the key tools that you have to, and I'm going to quote Robert Patch here, get the story of that person that's in front of you, to understand fully why they're there, what it is they're looking for themselves, what will help them understand whatever diagnosis you might come up with, and be able to really accept it and be involved in the therapy or the therapeutic remedies that you're giving them. And you're not willing to put and invest money into that? Well, I never got an answer to that question, to say the least. But I think that is still the challenge. While, as you said, and some of you have said, there's greater acceptance now for having trained healthcare interpreters, there is still a misconception that the healthcare interpreter is there to primarily facilitate the language exchange, and really not paying much attention to the fact that the cultural background, values, and beliefs that the patients bring with them to their understanding of what's happening to themselves and what is important to them and their families is not translatable only through language. There has to be some mediation, someone who can bridge that gap between the cultural and the linguistic gap. And yet, healthcare interpreters are not seen as partners in the treatment of a patient. And I think that's one of the biggest challenges that we have. I think the fact that NCIHC early on in the early 20s developed the Code of Ethics, the National Standards Code of Ethics and the National Standards of Practice was an attempt to say, we are professionals like you are. You have a code of ethics, you have standards of practice, so do we. You should know what those are. I don't think they do. So for me, that is still the challenge, is how do we get the medical world to understand that a healthcare interpreter should be a partner in the treatment of their patients, because they can really help bridge that gap of culture and language, and really also ensure, I hope, that the patients who may not be sharing the same cultural backgrounds and the same beliefs are treated with dignity and are able to get the best care that they deserve. That's my stance.
Thank you, Maria Paz. So Cindy.
I agree with Maria Paz's assessment. We've done a great job, I think, over these last 3 decades in trying to create a structure for understanding and growing healthcare interpreting as a profession. So, you know, understanding better the role, and then the ethics, which come out of the role, and then the standards, which are based on the ethics, and then the training, which is based on the standards. And then one would hope certification would come out of all of that. And I think we've done a great job with that piece of it. But even having the best interpreters doesn't matter if they're not being used appropriately, if they're not being engaged appropriately, and if they're not being given the resources they need in the right way. So I also am very much, you know, when I first started this, I kind of had this vision, and I said, we need to fundamentally change how US healthcare deals cross-lingually and cross-culturally. That's just it. Whenever somebody walks through the door, we need to be able to deal with those patients with their language and culture in mind. And I think we've done, you know, somewhat of a good job around the language part of it. And now I'm realizing that, you know, everybody runs scared from the word culture. Everybody is scared to bring this into the mix. And I'm proud that the United States is, I think, one of the few countries in the world that actually does include some degree of clarification and culture brokering and even advocacy under certain conditions in the role of the interpreter. Because if you go to Canada, that's not part of it. Australia, New Zealand, Europe, you know, it's very narrowly linguistic. So, you know, we've managed to broaden the role a little bit, but, you know, I think, you know, maybe not enough. And we haven't done enough systemically to make sure that hospitals and clinics and the administrations see that every point of contact with patients, language access has to be considered. You have to, every time that you might be interacting with a patient, you have to think, how are you going to do this with a patient who doesn't speak English well, or who is of a very different cultural group? So I think, yeah, I think that's my big concern about what we need to do right now, is the systems still have to change.
So thank you for that, Cindy. And I'm going to go out of order a little bit and go next to Julia, because you wanted to talk about specifically that context. So part of that culture, part of the environment that we're working in. Many of you have talked about, obviously, the need of new refugee and immigrant communities for healthcare interpreting when they come to the United States. So, Julia, you're really concerned about how the anti-immigrant sentiment and even anti-refugee sentiment in this country that has been fueled so much in the last couple of years makes it more difficult to sort of promote healthcare interpreting.
Yeah, thanks. I think maybe I'd like to contextualize this a little bit, because one of the things that I've had the opportunity to do over the last 20 years is to live in a variety of different countries and to engage in dialogues about interpretation, about cross-cultural healthcare, and eventually about migrant and refugee health policy in the EU, in Japan, traveling to different parts of the world, and then more recently, engaging in dialogues that were sponsored by WHO and the International Organization for Migration. And so in all of these conversations, the issues of language access arise. But, and I would say that there was an environment, perhaps in the early early 2000s, where people were very eager. They wanted to learn from good practice, from examples around the world. They were beginning to develop really innovative policy across countries, but also sort of multinational kinds of policy. And even in those early global consultations in 2010 and 2017, there was a sense of hope for how we might address these issues proactively at sort of a global and a national policy level. But towards the end of that period, I would say perhaps most importantly, starting with the Syrian refugee crisis in Europe, those attitudes, the will was there, but the fear was increasing because all of these topics, migrant health, refugee health, were becoming very politicized. And even well-thinking and good-minded Ministry of Health leaders were beginning to afraid to speak openly about making changes. And I think that what we've seen now, obviously, not just in the United States, but globally, how politically charged the issue of migration and refugee status and access to countries, to say nothing to access of health services, has become incredibly complex. And the dialogue is quite toxic now, and the pressures are everywhere. And so how is it that we in the healthcare system maintain that sense of humanity towards all of the people that we're trying to care for in the context of these broader political debates, which don't help at all? And yet we need to be on the front line and focusing the attention on the individual and on the health of communities. And I think when we talk about health equity and reducing disparities and equality of access, then some of these issues are still coming up. And I think that we're interested in them on a population level. But what happens when that intersects with some of these more toxic dialogues? And how can we be a positive force in those conversations in our communities?
Thank you for that context, Julia. So then let me go to both Shiva and Eduardo, who wanted to talk a little bit about technology. And Shiva, this is a little bit full circle that you referenced that, folks were resisting even phone interpreting at the time, and now we have video. COVID also brought telehealth forward in a whole different way. So talk about how technology has really impacted the field and the profession.
Yeah, and we're talking about artificial intelligence now, right? And we've seen such a huge way in which artificial intelligence is now starting to be used in healthcare in general, and of course in kind of language access and interpretation and translation. So I think one of the things that I have learned over the past 20 plus years is that we need to embrace and from within try to mold as opposed to that pushback, right? Because these things are going to happen and are going to be present because that's how evolution of systems happen. So think, for example, with phone and video, actually being able to embrace video interpreting and say, hey, this is a much better way of us being able to at least have some visual than the prior methodology, which was just phone. And then as we're thinking about telehealth, which is really going to continue to be a really important piece of provision of healthcare in this country, and actually has some very positive health equity impact, as well as thinking about the potential of the negative, right? But it does have a potential for positive. So really thinking about integration of interpreters within the telehealth visit, and how can we work in really creating the systems that actually integrate it, as opposed to saying, no, for those patients, for those visits, the in-person interpreter, that's what matters. Let's just put a stake on the ground. No, to just evolve and do that. And so I think that's been really important. I've seen in my work on a day-to-day basis how being able to work with others in putting ourselves in those spaces where technology is being talked about also provides a platform to continue to talk about the importance of language access, right? When you're not in those spaces, they're building it anyways, and you just don't have a say on how they're building it. And a good example for us is telehealth, and like being able to sit at the table with our both internal technology and Epic, which is, I'm sure, helps the electronic medical record system that many of those who are listening and are using in their system, and really influencing how they create a way to use the technology important. Last, I would say, I think the next frontier is artificial intelligence in healthcare and in interpreting. And certainly I think that thinking about what makes sense and what doesn't make sense in artificial intelligence, the same way that we're seeing health system thinking about my chart messages that are going to be written by artificial intelligence and then reviewed by somebody. Does it make sense? In what way? Because I think our gut reactions, my gut reaction, I will recognize as, again, somebody who has spent so much time with patients and interpreting and feels so strongly about the place that a medical interpreter, a healthcare interpreter has, is to say, I want it, get away from me. But we have to find a way forward on how do we, what makes sense with this technology and how can it help? Because we definitely have, I mean, and that's a whole other topic, but there is not enough interpreters, not enough healthcare interpreters.
So thank you for those projections. Eduardo, do you want to add anything to Shiva?
What was difficult of this question was, what is the most significant challenge? I would say there's probably not a single challenge by multi, and probably everything that has been mentioned is true to some degree. I would say that the technologies that exist today are really game changers, and they would have been unthinkable when I started working, which was pre-internet. And this is tied with another question that maybe in the interest of time we'll skip. What was the most significant changes in my time as a medical interpreter? Was all face-to-face, and now there's all these new technologies. I was going to list what some of these technologies are. Voice to text, to be able to speak and dictate and convert any text and closed caption it live, and then machine translate it live. So that's already exists, and it maybe is being used, and it's going to get better. What's missing from a lot of these tools, well, anyway, from the point of view of a translator or an interpreter, tools like the ability to, from a corpus or a group of a text or something that I need to translate, or a conference where I'm going to need to interpret and I need to research the topic, the ability to, from a corpus of material, to generate a glossary by clicking, almost without being an expert, without being too much of a tech guru. Those are some of the technologies that are changing the game for how we translators and interpreters are practicing, because these are now medical interpreters, which used to be live, are almost like you're working in the booth. But in the booth, you have Aladdin's lamp, because you can click and do magic with all these tools. But there's also a lot of ethical issues related to confidentiality. If you're using these tools, or if you're using AI, any of the stuff that they offer you, quote unquote, free, is it confidential or not? So if you're using these tools now, professional translators have ways of using these tools in a way that we are in control of the machine. The machine is not in the control of us. And what's the most important challenge for me would be to not forget about our humaneness, and that artificial intelligence has to be in the interest of humanity. And so there's a heck of a lot of ethical dilemmas. You can read about it every day in the newspaper nowadays.
Yes. All right, so we're unfortunately coming to the end of our panel. So I'm going to ask each of the founders for a 30-second response, so a lightning round. So in a phrase, tell me what your hope for the future of healthcare interpreting is. Just a single phrase, 30 seconds. So Let me start with Cornelia.
So I wanted to talk about developing a law, although I actually had two answers, but I think I'll talk about the law. Or or else I have another recommendation too. I have two.
So just give me a 30-second, what your
Well,
hope
you
is
know,
for the
it
future.
actually takes, okay.
We only
so,
have 3 minutes left in the panel, Cornelia.
Well, okay, so in my experience as a director of a small agency, our biggest problem was antagonism between the hospital and the provider. The way the civil rights law is
sorry,
set up.
just give me a 30-second. What's your
I'm
hope for the
giving you,
future?
I'm giving you one. The civil rights sets it up so that one agency, the advocate, submits a complaint, and the other agency, the provider, is like the target, and it develops enmity between the two. And I think there's an interesting new movement in healthcare called value-based healthcare, where the pay is developed, the hospital receives money, not based on the number of interpreting visits, but the quality of care. And this means that a value-based care, that if there's that hospitals are reimbursed for interpreting services if on the condition that the LEP patient doesn't return again to the hospital because of a language barrier. And this approach could finesse disagreements about qualified interpreters and also about cost that now exists between interpreting providers and facilities. And there are, I think, big obstacles if there would be a shared interest in a national quality standard and funding arrangements that led to quality service. My recommendation.
Thank you, Cornelia. So Tuvan, you want to say something about the future, particularly for those that speak languages other than English? You're on mute. You're on mute. Can you unmute yourself?
Thank you. So my hope is that we continue to let the LEP community, family and members to say, I have the right with my service. Because sometimes they're afraid, and they're afraid to speak up. So they're gonna go find somebody else, because they told me, because they seek for me and they look for me and say, well, they use this machine, the voice, I don't understand. The accent is from the North Vietnam and I'm from the South. I do not understand her. Can you come? Because they understand I'm from the South, but I'm clear and correct. The patient understands my language and I understand my patient language. And that is so important. And, you know, provider does not see that. So
Thank
it's
you.
up to us to help our LEP community.
Thank you. So Julia?
Very quick. I think we need to recenter the importance of the healthcare provider and patient relationship. It's squeezed by cost, it's squeezed by time. We can't communicate, we can't care for people, regardless of the language they speak, if there isn't enough time to do this. We need to change the incentives in the healthcare system.
And Eduardo?
I hope we are recognized as experts in what we do. And that part of that is us becoming aware that we are experts, that we are better than machines because we are human beings. We have feelings, we're capable of empathy, we're capable of understanding other people's feelings. Machines can't do that. They're good tools at our disposal, but we are the experts. We need to assert that and become aware of that strength in ourselves, our humanity.
Thank you. And Sheila?
I think what I would say is that given the role that I have now, that's as Chief Diversity Officer, I see lots of conversation about health equity, but I don't see, even though for us it's obvious, I don't see a direct understanding that language access is part of health equity. And so I think and actually many Chief Diversity Officers don't have language access reporting to them.
Great. Maria Paz?
I want to echo a lot of what been said around the importance of keeping humanity in the interaction between the patient and the provider and into the medical system itself. And I'll stop there. There are other things, but I'll stop there.
And Cindy.
It's very comfortable as interpreters to talk to interpreters. You know, we all like each other. We all understand where we're coming from. We've got to get out of this box. We've got to go back to where we were at the beginning and bringing in providers and going out and talking to administrators. And, you know, look at Julia. Julia came to us from politics. And I have to say, when you first came, Julia, I remember thinking, what? You know, a representative's office? But we need to get, you know, I don't know if into lobbying, but, you know, we need to start working again as advocates on the system. We have a lot to offer now. We've got lots of tools and expertise and knowledge and experts, but we have insulated ourselves in our little world of interpreters. And we need to turn outward now, I think, and take what we've learned back out and really get involved with all these other stakeholders and start to push this issue. You know, maybe our entry now this time will be, as Shiva says, through the diversity work.
And as Shiva also noted, and Eduardo, then talking to people in technology, talking to people in HR,
Yes.
talking to people, Cornelia, who are doing payment reform and doing value-based payments. So really being engaged in all those different conversations. So as we expected, we could probably have this conversation for several hours rather than 1 hour. So I want to thank all the founders who participated and turn it back
Thank
to
you,
David.
everybody.
Thank you, Ignatius, and thank you to all the founders for all of your work, your vision, as I think it was Dr. Julia said, your persistence, right? To be able to start something like this without knowing where it was going to go. And now we can look back and see all the benefit of all those seeds that you all planted. And now we get to be here and we get to experience our industry in a much stronger way because of all your efforts and tireless hours that no one else saw and conversations that no one else was around for. And now we get to see our industry progress. And the mission of NCIHC, again, I've said this a couple of times, but it's just so important to go back to, is it's to promote and enhance language access. And every little step that all of the founders put in, all the bricks that were laid or help building this foundation. And the cool part now is that there's still so much more to do. And that's really where all of us here today get to continue to carry that torch and continue to lay more bricks. There's a lot more to be done. We just heard all of the takeaways from all the founders. That's our mission now, is to see all of that through, and we all get to play a vital role in that. What other committees, what other work groups are going to be started to help bring these things together. So again, thank you, Ignatius, for facilitating, and to all of our founders. We're so grateful for you.